أعزائي طلاب المرحلة الرابعة السلام عليكم ورحمة الله وبركاته. So this lecture is the third lecture in the chemotherapy series, and we talked previously about the principles of chemotherapies, some chemotherapy classes, and today it is the second part of alkylating agents that we talked about the first part in the previous lecture. So in this category, we have around 4 drugs. Meclorithamine is a derivative of nitrogen mustard, and this one is now used to treat lymphocytic cancers due to its ability to induce lymphocytopenia. And then we have melphalan, and melphalan is another derivative of nitrogen mustard and is used to treat multiple myeloma. This drug is called has the bifunctional alkylating agent, which means it has the ability to alkylate or make bonds with nucleophilic sites on different DNA bases. So the alkylating agents, if they are not bifunctional, they have ability to just to bind to one site or to one base of DNA, let's say one alanine or one thymine or one adenine, etc. But this agent has the ability to make 2 bonds or 2 covalent bonds with 2 different DNA bases. This drug is given orally and has the ability. This drug has the ability to, as we said, multiple myeloma, but there is a need to for a careful monitoring from patient to patients due to the huge variation in the intestinal absorption. The dose of melphalan, accordingly, so the dose of melphalan should be adjusted if the patients have some disorders in the gastrointestinal tract and urinary tract, and this monitoring is done by platelet and white BC counts. Then we have chlorambucil, and chlorambucil is also another bifunctional alkylating agent and is now used to treat chronic lymphocytic leukemia. Then finally we have busulfan, and busulfan is alkylating agent and now is used to treat chronic myelogenous leukemia, and this drug is caused a common side effect, pulmonary fibrosis, or it is called busulfan lumps. And then finally, all these agents, all these other alkylating agents have the ability to induce leukemia, so they are all leukemogenic agents. Here we're done with the alkylating agents, and now we will start with another class. And this class is the microtubule inhibitors. But before moving forward with these agents, it is important to mention what are the microtubules. So there are what it is called mitotic spindles, and these spindles are formed during cell division. Each spindle is composed from chromatin in addition to microtubule. Protein is called tubulin. So the major function of these spindles to provide a skeleton or routes for the genetic materials, chromosomes, in order to be divided or to be distributed from the original mother cell into the daughter cells. So they are providing skeletons for moving genetic materials into daughter cells in equal parts. So that there are now a couple of drugs that have been developed in order to target this process and make this process abnormal. And we will see there are different mechanisms in order to modify this process by using chemotherapies. So originally we are targeting polymerization and depolymerization of microtubules. It means like forming the microtubules and then depolymerization of the formed microtubules. The first agents that we have in this class, we have vincristine and vinplastin, and these are vinca alkaloids. Then there is another or a new agent has been developed in this category is called vinorelbin, and vinorelbin is also a vinca alkaloid and works by a similar mechanism. Vincristine now is used to treat lymphoblastic leukemias, different kind of tumors in addition to Hodgkin and non-Hodgkin lymphomas. While vinplastin now is used in combination with bleomycin and cisplatin to treat metastatic testicular carcinoma, and also can be used to treat another kind of tumors such as Hodgkin and non-Hodgkin's lymphoma. While vinorelbin now is used to treat advanced non-small cell lung cancer, either alone or in combination with other chemotherapies. The mechanism of action, so let's take a look here on this figure. So in the metaphase of the cell division, the microtubules are formed in this phase in order, as we said previously, to provide routes for the chromosomes and to be divided into equally into the two daughter cells. And cells are done this mechanism through forming these microtubules, and microtubules, as we said previously, is composed from the tubulin in addition to chromatin. So this is what it is normally happening in the cells in the metaphase during the anaphase in the division of the mother cell into two daughter cells. So vinca alkaloid interferes with this step because they are interacting with the building unit, with the building units of the microtubules. So they are preventing the tubulin from binding to each other from polymerization in order to form microtubules. So they prevent all units or each unit separated from the others and is not composing a chain of tubulin, and they stay disintegrated like this, and there is no formation for the mitotic spindle. And as we said, if there is no mitotic spindles, there is no equal division for the chromosomes from the mother cells into two daughter cells. It is like just frozen the cells in the metaphase, and cells die on this state. Then in the pharmacokinetics, these agents can be given intravenously in order to provide rapid cytotoxic effect. However, this way of administration, these drugs could cause hyperuricemia due to oxidation of purines that are released from DNA fragmentation. The vinca alkaloid, it is they are metabolized in the liver, and they are eliminated in bile and feces, and maybe there is a need for monitoring in patients with liver failure or liver diseases. Adverse effects. With the adverse effects, vincristine and vinplastin, both of them could cause phlebitis and cellulitis, and this happens due to extravasation of drugs during the IV administration. And this, it could be a serious side effects if it is like extravasation of large amounts of these drugs during administration. In addition to these common side effects, we have other side effects such as gastrointestinal side effects in addition to alopecia. A serious side effect could cause by vinplastin myelosuppression, while with the vincristine, the more commonly happens with vincristine is peripheral neuropathy and constipation. Myelosuppression happens, but less frequently with vincristine. These agents should not be used by intrathecal administration due to this, due to a technical reason. If there is a potential for error or a mistaken administration of these drugs during intrathecal administration could be fatal. So it is better either carefully monitoring or administered by another route. Then we have paclitaxel and docetaxel. These agents also, they are closely related agents, I mean in the chemical structures, and they are now used to treat different kinds of tumors, such as with the paclitaxel is now used to treat advanced ovarian cancer, metastatic breast cancer, in addition to non-small cell lung cancer, if it is administered with cisplatin. While docetaxel is now used most commonly for prostate, breast, gastrointestinal, in addition to non-small cell lung cancers. The mechanism of action, so let's put in our mind the previous slide and what is going on during the metaphase. So briefly that in the metaphase, there is a formation for the mitotic spindles, and these spindles, as we said, just to provide equal division of the genetic materials between the two daughter cells. In the presence of paclitaxels allows for the mitotic spindle to be formed, but the formed ones, these mitotic spindles that are formed in the presence of paclitaxels, they are overly stable. So they are polymerized, but they are not depolymerized after the mitotic spindle done their job. So they are formed in the original cells, but they are not depolymerized in the daughter cells, which is causing like a frozen for cells in the anaphase. So the cells are died due to non-polymerized mitotic spindles. So they are working in a different ways. Let's say in a different side of the formation of mitotic spindles. With the zinc alkaloid, there are non-polymerized mitotic spindle, while while here we have non-depolymerized mitotic spindles. Pharmacokinetics. These agents are metabolized in the liver and they are excreted by the biliary system, and maybe there is a need for dose adjustment in the presence of the hepatic diseases. Adverse effects, the dose-limiting toxicities with these two drugs are neutropenia and leukopenia. Peripheral neuropathy could happen, but it is less common than the two adverse effects, neutropenia and leukopenia. In addition to all these side effects, there is a risk of hypersensitivity reaction, which could be mild, just like urticaria, and to very severe kind of hypersensitivity reaction, such as severe hypotension and shock. So sometimes it is recommended to use anti-allergic drugs such as dexamethasone, diphenhydramine, and H2 antagonists. So here we're done with the microtubule inhibitors, and this is a new class in chemotherapy, steroid hormones, and their antagonists. So some tumors are responsive to hormones in a certain way. We have in general three types of tumors response to hormones in a certain ways. The first kind of tumors, what it is called hormone responsive, and these tumors regresses in the presence of the hormonal therapy. So if we are giving to the patient certain hormones, these hormones causes regression, tumor regression. The second kind of tumors that are response to the hormonal therapy called hormone dependent. And this kind of tumors regress in the presence or in the absence of the hormonal stimulus. So if we are removing or just stop the hormonal supply to the tumor, there is a tumor regression. And the third part, or the third kind of these tumors, it is like a combination of these two previous tumors. So either we have hormone responsive or hormone dependent, or a combination of these two tumors. Removal of hormonal stimuli from hormonal dependent tumor can be done by surgery, chemotherapies, or sometimes a combination of both these two. So it is dependent on the kind of the tumor. But there is an important features for the hormonal treatment as chemotherapy, the presence of intracellular receptors for these drugs, because we know most of the steroid hormones work inside the cells. The first one, or the first drug in this category, tamoxifen. And tamoxifen is a selective estrogen modulator. We took with the osteoporosis this term, and it means like this drug has agonist to estrogen receptors in certain tissue, and it is an antagonist to estrogen receptors in other tissues. So it depends on the kind of the tissues. In this case, in the case of tamoxifen here, it is antagonist in breast tissue, while it is agonist in other tissues such as bone and endometrium. This drug now is used as a first-line treatment for estrogen receptor positive breast cancer, and also can be used for breast cancer prevention in high-risk women. Mechanism of action, it is very direct mechanism of action. So this is an active receptor, steroid receptor inside the cells, and it is activated in the presence of a steroid, depending on the type of the steroid. Then after activation, there is a movement for this complex between the receptor and the ligand into the into the nucleus, and inside the nucleus, they bind into the DNA, and there is activation for transcription and synthesis RNA. After synthesis of RNA, there is an increase in the production of proteins, and this causing the effect of this steroid. So in the presence of tamoxifen, it is a competitive inhibitor for steroid. It competes with steroid to the steroid receptors and prevents steroids from binding to the steroid receptors. Pharmacokinetic, tamoxifen can be used orally. It is partially metabolized in the liver, but this metabolism in the liver leads into two kinds of metabolites. Some of them have agonist activity, while others have antagonist activity. And this leads actually to the side effects that are associated with using tamoxifen. Unchanged drug, in addition to the metabolites, all of them are excreted in the bile and feces, and it is there is a kind of inhibition or protein inhibitor is done by tamoxifen, and this happens mostly to the cytochrome 3A4 and beta glycoprotein. The most side effects that are related to the tamoxifen, it is a kind of estrogen side effects, such as hot flushes, nausea, vomiting, skin rash, vaginal bleeding, and discharge. Also, the tamoxifen has the potential to induce endometrial cancer, even if it is like it is a kind of antagonist to the estrogen receptor, maybe in the breast tissue, but not in the endometrium. Other toxicities that, as we said previously, it could be related to the high level of estrogen. It is thromboembolism. Then we have other two agents, fulvestrant and raloxifene. And raloxifene also, we discussed this drug in osteoporosis. It is also a selective estrogen modulator. So fulvestrant, this drug is now given intramuscularly by intramuscular injection for patients with hormone receptor positive metastatic breast cancer. So this agent is not serum. it binds to estrogen receptors and blocks estrogen receptors. While raloxifene is, as we said, it is a SERM, and it has agonist activity in the bones and inhibits the bone resorption, while it has antagonist activity in the uterus and the breast tissue. This agent reduces the risk of estrogen receptor positive invasive breast cancer in postmenopausal women. Both drugs could cause hot flashes, erythroalgia, myalgias, and erythroalgias. Then we have aromatase inhibitors. Aromatase reaction, it is very important, especially in postmenopausal women, to form estrogen from androstenedione. And this is what it is called, extra-adrenal synthesis of estrogen from androstenedione. This reaction mostly happens in places such as liver, fat, muscle, etc., and causes an increase in the level of estrogen in postmenopausal women. Peripheral aromatization is an important source, as we said, for estrogen in postmenopausal women, and this point has been used to develop aromatase inhibitors in order to target or to treat breast cancer in postmenopausal women. Then we have anacetrozole and letrozole, and both of these drugs are non-steroidal aromatase inhibitors. These agents are considered now as a first-line treatment for breast cancer, especially in postmenopausal women. They are active, they can be given orally and cause almost total suppression of estrogen synthesis. Anacetrozole and letrozole do not predispose patients to endometrial cancer, and this is an important feature, maybe is not noticed with certain agents, and as we see here with the tamoxifen. And both of them are extensively metabolized in the liver, and they are primarily, parenting drugs. In addition to metabolized, they are primarily excreted in the urine. Then we have the exemestane, and exemestane, this drug is irreversible inhibitor of aromatase, may have a greater potency than the anacetrozole and letrozole. This also can be used orally. This drug has certain kind of interaction with cytochrome 3A4. Because of the metabolites are excreted in the urine, there is maybe a need for dose adjustment or monitoring in patients with renal failures. Then finally, we have the side effects with this drug is nausea, fatigue, hot flash. It is kind of activation of some kind of the estrogen receptors. And finally, also, this drug could induce alopecia. Then here we have agents that are working in a different way. Also, they are antagonizing the estrogen effects or androgen effects, but in a different way. So it is not that there is a hormone called gonadotropin releasing hormone that is released from the hypothalamus right here. And this one, it activates the receptors in the pituitary glands, and activation of the pituitary glands or the receptors in the pituitary glands causes releasing certain hormones. Mainly, we have two major hormones, luteinizing hormone, LH, and follicular stimulating hormone, FSH. LH, it is an important stimulus for secretion of testosterone by the testes, while FSH stimulates the secretion of estrogen. So these agents have been developed. They have chemical structures, or their structures are similar to the GnRH. We have three major agents here. We have leuprolide, goserelin, and triptorelin. All of them, as we say, they are analog of GnRH. They are and they occupy the GnRH receptors in the pituitary gland and lead to desensitization of this gland to the GnRH and causing decreasing in the releasing of FSH and LH. It is like a kind of the competition with the GnRH to the GnRH receptors in the pituitary glands and blocking the effect of GnRH, and this leads to decrease in the release of LH and FSH from the pituitary glands, and of course this causes decreases in the level of androgens and estrogens. Response to leuprolide in prostate cancer is equivalent to the orchiectomy, and this means like removal of testes with the regression of a tumor and relief of bone pain. And this is an important feature with the leuprolide. These drugs have some benefits in premenopausal women with advanced breast cancer, and they are they're used now. It is or replaced using estrogens and therapy for prostate cancer. So it is now because they have better efficacy than estrogen in prostate cancer, they replaced the treatment of prostate cancer with estrogen. Goserelin acetate, it can be used by subcutaneous implant, while triptorelin can be used by IM injection. Levels of androgens in a prostate cancer patient may be initially rise, and this is maybe due to partial agonists can be induced by these drugs, but then there is let's say a complete fall in the levels of these androgens to the level of castration. It means castrations, it is orchiectomy. And the adverse effects that are related into these drugs, it could include impotence, hot flushes, tumor flare, and minimal compared to those experienced with estrogen treatment. So in the efficacy, they are better, and in the side effect profile also, they are better than estrogen. Then we have the anti-androgens, and in this class, we have certain drugs, flutamide, nolotamide, bicalutamide, and enzalutamide. All of them are oral agents, can be used now as tablets to treat prostate cancers. They are competing with the natural hormone for binding to the estrogen receptors and prevent the action of androgens on the prostate. So they are direct competitive inhibitors for androgens in the androgen receptors in the prostate. Adverse effect could include gynecomastia, and this is due to low androgen levels, constipation, nausea, abdominal pain. Also, these agents could lead to the liver failure, as noticed with the flutamide. So here in this figure right here, I want to take a minute and shows that activation of hypothalamus and releasing GnRH. Then after that, there is a release for the FSH and LH. So this step is blocked by the, as we said, by the agent leuprolide and the others. While here we have flutamide, and flutamide is targeting this step. So after LH and FSH, there is a release of testosterone from the testes, and this step can be blocked by the anti-androgens. While on the other side, and with the in the women, the releasing from the adrenal cortex, as we said, maybe there is a secretion or enhancing the release of estrogen in postmenopausal women happens in other organs such as the adrenal cortex. So in this step, we can use aromatase inhibitors to target this step, or using drugs that are directly competitive inhibitors with the estrogen or the estrogen receptors, such as in the case of breast. Then we have platinum coordinating complexes. And in this class, we have three major drugs: cisplatin, carboplatin, and oxaliplatin. The first one was cisplatin. Then after that, carboplatin has been developed. But these two drugs, they are hugely different in the potency, pharmacokinetics, uh, other, other characteristics such as dose-limiting toxicities, adverse effects. And this led to the differentiation in the using of these two drugs to different kinds of cancers. So cisplatin has a synergistic cytotoxicity with radiation and other chemotherapies. It has found a wide application in the treatment of solid tumors, such as metastatic testicular carcinoma, or, let's say can be used in combination with vinblastine or bleomycin, ovarian carcinoma in combination with cyclophosphamide, or alone for bladder carcinoma. While carboplatin now is used for patients who cannot be vigorously hydrated, because there is we will discuss this in a minute. There is a serious side effects can be induced by cisplatin, and one of the like nephrotoxicity, and this side effect can be prevented or reduced by using hydration. So if patient cannot tolerate vigorous hydration, it is now recommended to use carboplatin because this drug has less potency to induce this side effect. Or the patients could suffer from neuro-ototoxicity. As we said, these drugs are hugely different in their uses and in the side effect profiles. So the preference for using one over the another, it is now mostly related to the side effects that can be induced by any of these drugs. Oxaliplatin is now is developed after that and is closely related to carboplatin and is used maybe mainly now for colorectal cancer. Mechanism of action. The mechanism of action of these agents, it is much similar to the alkylating agents. So in the presence of high chloride environments, these agents stay, or especially with cisplatin, stays in the neutral species. So it is in original form. While after entering into the cells, and it is known inside the cells, there is low chloride levels inside the cells. And this leads to generate an active metabolite. It is a similar story that we discussed with the alkylating agents. Then the active metabolites, it has the ability to bind to guanine in DNA and forming inter and intra-strand cross links. And this means this drug has the ability to make links or alkylating effects in the same strand of the DNA, because we know there are two strands in DNA, but this drug has the ability to bind to one strand or to both strands at the same time. This causing the cytotoxic effects of this drug due to the inhibition of the activities of the DNA. Alkylating effect to the DNA prevents DNA from opening or unwinding, and we know if there is no opening for DNA, there is no transcription for RNA, and there is no synthesis for the proteins. So this is in general the mechanism of action of these drugs. Cytotoxicity can be occur in all stages of the cell cycle, but I think the mostly these drugs are affecting the G1 and S phases of cell dividing cycles. Pharmacokinetics. This agent can be used by intravenous administration and also can be given by intraperitoneal administration in case of ovarian cancer, or intra-arterial administration in case of other organs, such as, so in this way we have either intravenous, intraperitoneal, or intra-arterial administrations. The highest concentration or these drugs are accumulated in certain tissues such as liver, kidneys, etc. But they have a poor ability to penetrate the cerebral spinal fluid blood-brain barrier. Adverse effects. As we said in the previous slide, these drugs are different in the side effect profiles. So severe nausea and vomiting in most patients could happen with cisplatin administration. And these side effects could continue for up to 5 days. So it is highly recommended to pre-medicate patients with antiemetic agents before cisplatin administration. The majority of limiting or the major limiting toxicity that is related to this drug, as we said, the nephrotoxicity. So it is recommended to tell the patient for vigorous hydration. And also there is a potential in this drug to cause or induce other toxicities such as ototoxicity with high frequency of hair losing and tinnitus. Now, on the other hand, we have carboplatin. And as we said also, this drug has a low potential to induce nephrotoxicity, and also it has a low potential to induce other side effects such as nausea, vomiting, in addition to neuro and ototoxicity. But this drug could induce myelosuppression, and this is considered the dose-limiting toxicity with carboplastin. Oxaliplatin, this one could induce a different side effect. Could induce cold-induced peripheral neuropathy, and this one, it is a reversible neuropathy, and also has the ability to induce myelosuppression and certain kind of peripheral neuropathy. Hepatotoxicity, it also happened with this drug, and these agents, all of them could induce hypersensitivity reactions, and this needs to use anti-allergic drugs, as we saw previously, such as dexamethasone, diphenhydramine, or H2 antagonist. Then we have topoisomerase inhibitors. And topoisomerase, it is important here to understand what is the function of topoisomerase. Then after that, it is easy to understand the function or the do is doing by the inhibitors. So these agents exert their mechanism of action via direct inhibition of topoisomerase enzymes, and we have in general two kinds of topoisomerase, as we will discuss now: topoisomerase 1 and topoisomerase 2. The first agents in this class, we have camptothecins, and this is the original drug. Then we have two derivatives that are originated from this alkaloid, irinotecan and topotecan. These drugs are now for topotecan, now is used to treat metastatic ovarian cancer when the primary therapy is not very effective. And irinotecan, this one now is used in combination with 5-FU, 5-fluorouracil, and deoxyvarine to treat colorectal cancer. The mechanism of action of these agents, as we said, it is related to the topoisomerase. It is a direct inhibition to topoisomerase 1, and this is an essential enzyme for DNA replications in human cells. So there is an active metabolite of irinotecan. It is called SN38, and this one, it is very potent in comparison with the original or the parent drug. Topoisomerase relieve torsional strand in DNA by causing reversible single strand breaks. So let's take a look here on this figure just to explain more about topoisomerase. During replication, it is important for the two strands of DNA to be unwound or open in order to give enough space for other proteins to combine with each strand or both strands of DNA and transcript DNA into RNA. While in the presence, what it is called supercoiling DNA, as in this case, this leads, while in the presence of supercoiled DNA, as in this case, it is hard for proteins and other important organelles to become close to DNA and start transcription. So what topoisomerase 1 does, it makes nicks or breaks in any of the DNA strands, and this allows to twist the other strand over the nicked strand and open the supercoiled DNA. So in the presence of inhibitors such as topotecan, this process doesn't happen, and this means that the DNA stays in the supercoiled form, and this supercoiled form doesn't allow for any transcription for DNA or proteins, and this prevents cell divisions or put the cells in the ready state for cell divisions or synthesize necessary proteins and other things that are important for cell division. So this is, in very simple words, the mechanism of action of topotecan. Adverse effects that are related to these drugs, they could induce bone marrow suppression, especially neutropenia, and this one is the dose-limiting toxicity for topotecan. Myelosuppression is also happening with irinotecan, and acute or like these drugs could induce acute or delayed delayed diarrhea with irinotecan, and this required the treatment with atropine to induce constipation, or using high doses of loperamide to stop these serious side effects. This serious side effects is mostly related to irinotecan. Then we have etoposide. Etoposide, it also works on topoisomerases, but this one is more specific to topoisomerase 2. And we will discuss this in a minute. So this agent blocks S and G2 phases of the cell cycle through targeting the topoisomerase 2. So there is, let's talk about the other features, then I will go back again to the mechanism of action. Now, etoposide used to treat lung cancer and in combination with bleomycin and cisplatin for testicular carcinoma can be used either by intravenous or oral routes of administrations, and the very serious or common side effects with this drug is the myelosuppression. So let's go back to the mechanism of action. So here it is like a close look to the process of unwinding or relieving the DNA torsion through using this important enzyme topoisomerase 2. And this complex is bound to the double strand of the DNA and makes breaks in the both strands, unlike topoisomerase 1, which makes only a break on one strand of DNA, while this one breaks both strands of DNA. But this complex is a transient cleavable complex, so it is just after breaking the two strands of the DNA, there is after that immediately there is sealing for both strands of the DNA. While in the presence of the etoposide binds to the to topoisomerase 2 and prevent topoisomerase 2 from releasing itself from the double strand of the DNA. So it stays like this, and this leads to the continuous break in the DNA. So it means there is a reversible double strand breaks in DNA, and this means there are no continuation or no new sealing for the breaks for the breaks in the double strands of the DNA, again with the remaining part of the DNA. So just to clarify this more here, if we are imagining the topoisomerase 2 is bind here and makes a break here or nick here in the both strands, but this should be transient, it's not for a long time, and after a while there is it should be sealing again. While in the presence of topoisomerase 2, etoposide, this prevents the topoisomerase from releasing itself from the both strands of the DNA. So it means this break becomes irreversible and continuous. And of course, this is going to prevent DNA replication and RNA synthesis. Then we have antibodies, and antibodies in this class we have various drugs. And monoclonal antibodies, it is very important now class in the treatment of cancer, because these drugs very specific, they are direct to specific targets in the cells. And also there is another reason, they have a different toxicity profiles from all other chemotherapies. And this causes a combination of these agents with other chemotherapies with different profiles of side effects. And we talked about this in the, I think in the first lecture about the, let's say, the principles of combinational therapy by using drugs with different mechanism of actions and different toxicity profiles. So here I want you just to focus on 3 drugs from this table: bevacizumab, cetuximab, and trastuzumab. These two, the first one, bevacizumab, and this one targets VEGF, vascular endothelial growth factor, and this is important factor to form new blood vessels for the tumors, so they inhibit vascularization of the tumors. The major side effects, and of course, if there is an inhibition for vascularization, this means there is not enough blood and nutrients reaching to the tumors, and tumors die or shrink in the size. In the side effects, we have this agent could induce hypertension, gastrointestinal perforation, proteinuria, or wound healing problems, in addition to bleeding. Cetuximab, it targets a different target. This one is working on EGFR growth factors, endothelial growth factor receptor, and complete, and it is competitive inhibitors for epidermal growth factors and prevent growth of the hormones, growth of the tumor, sorry, and inducing apoptosis. So it is just a direct, direct competitive inhibitors to epidermal growth factors and causing shrinking in the size of the tumor and induce apoptosis in the cancer cells. And the side effects, this drug could induce scar rash, electrolyte wasting, infusion reaction, and finally diarrhea. Trastuzumab, this one works in a different targets. This one also inhibits tumor proliferations and cell cancer overgrowth through targeting HER2, and this one represents receptor for the growth factor that is responsible for the epidermal. So this one, it targets directly the HER2, and HER2 is responsible for the growth of the, so it directly binds to the receptor of epidermal growth factors. So this means that we have here a human epidermal growth factor receptor type 2. This is what this drug targeting. Well, the major side effect that could be induced by this drug is cardiomyopathy, infusion-related fever, chills, pulmonary toxicities, headache, and nausea, vomiting. So here we are gonna to stop here with the antibodies, and we will finish the last part in the coming lecture with the chemotherapy. Of course, if you have any questions, or certain concerns, just let me know in the comments, and I will answer this accordingly. Thank you very much.